Dr. Kim?
Hello.
Okay, you're waiting.
Yeah.
Okay.
Welcome again to SNU Hospital Cath Lab. I'm H.S. Kim. This is my colleagues, Dr. Kang Ji-hoon, Dr. Yang Han-mo, and many members. And Dr. Ki Yu-jung will interpret TE finding, and Dr. Nam Garam is supporting me to do anesthesia for this patient, general anesthesia. I introduce my case. Slide, please. Plus, 83 years old female developed acute heart failure, acutely managed and referred to me in SNU hospital. Severe AS was confirmed. Plus, of course, chronic renal failure, GFR 40 is one of risk factor. That is important because it is poor prognosis factor after TAVI. Diabetics and smoking. Presentation is dyspnea, recently aggravated. Plus, medications and target is severe symptomatic AS. Plus, surgical risk score is low, 3.4%. Plus, chest X-ray ECG was acceptable, no conduction delay. Plus, echocardiography showed normal contraction, mild AL, valve area is 0.9 square centimeters, tricuspid. Plus, aorta angiogram showed not so ugly. Heart position was acceptable for absolute, not horizontal. Plus, aortic valve shows little calcification. Annulus LVOT, no calcification. Size is 21-20. Plus, ST junction, a little bit calcified. Size is 22. Sans valsalva is good. Plus, coronary height is 13-17. ST junction height is 18, borderline 21. Plus, right iliofemoral artery looks good, minimum more than 6.5. Plus, left more tortuous than right, minimum 0.2 millimeters. Plus, to summarize the calculation, annulus 21, ST junction 22, height of ST junction 18, 21, partly calcified. Plus, when we choose sapien, it corresponds to 23 millimeter with 9% oversizing with nominal inflation. Plus, when we choose absolute, it corresponds to 26 pro with 20% oversizing. That is my favorite digit, 20%. Plus, there are two issues. The first one is octogenarian female with low surgical risk. Now, such kind of patients is also a prototypic indication of TAVI. The second thing is how to select valve type and size. Plus, why not sapien-free 23 millimeter valve? 23 is the smallest valve available in South Korea, so I don't like smallest valve. In general, it is okay. Why not sapien? But when you consider trial-ST junction, partly calcified, a little bit low, narrow, thus I prefer absolute pool 26 millimeter. Plus, then I will show you the angiogram taken together, today. Angio, please. Okay. We punctured common femoral artery under fluoroscopic guidance. Plus, then we performed root arterography at LAO 9 degree. Mild to moderate AR was noticed, little calcification. Plus, so we inserted system to LV plus plus, and perform the double tracing, plus. Pressure 보여줄까요? Yeah, as you can see, the pressure, there is significant pressure gradient between two chambers, and pulse pressure is very wide, corresponds to moderate AL. This is the stage that we have taken today. Is there any comment and question? Okay. Then I will deploy Avatar 26 directly. I will insert Safari wire into left ventricle. Yeah.
Hi, Dr. Kim. Meanwhile, you're working. It's Eric again. I told you I'm following
Ariel.
you. And two questions. One, do you plan to perform a predilatation here? I didn't hear you mention that. And the second question is regarding your puncture. You have shown us in the last session that you are using a drum that I'm going to buy for Tel Aviv as well in order to reduce irradiation. But at the same time, you're wasting such an awful lot of irradiation on puncturing while you can do it so easily with an ultrasound and very accurate.
Okay.
So
I will accept your recommendation. And if Sono is available, we change the system from fluoroscope guidance to Sono guidance. Thank you very much for your recommendation.
thank you.
Eric,
I skipped the pre-ballooning because the valve area is large enough, 0.9 millimeter square centimeters. There are two personal situations that I do pre-ballooning. The first one is very tight stenosis, less than 0.5, 0.4, 0.3. The second situation is there is ambiguity in size determination, such as bicuspid AES. Other case, I don't do pre-ballooning because more touch may increase stroke risk.
Yes, Reggie.
one question about access. So ultrasound alone, there's a problem sometimes. You risk high puncture with a high bifurcation if you use ultrasound alone. I think using ultrasound alone needs to be only done by true experts. For most others, a combination of ultrasound and fluoroscopy, I think, will be the safest.
Yeah, as a matter of fact, the question was provocative because he showed before the drum, but I think that whenever you start to puncture with an ultrasound, practice makes perfect, and it becomes so much easier. So yes, I absolutely agree, but it's just a matter of time that everybody is going to use the ultrasound.
Okay.
And I totally agree to what Dr. Kim mentioned regarding the tightness of the annulus. You want to mention something?
Deploy.
Okay.
I start deployment.
Was there any coronary disease in this patient? No.
Testing. Okay. 조정하고요. Deploy. Stop. Deploy. Deploy. Stop. Testing. Depth is about 6 millimeter now. Deploy. Deploy. Stop. I control the position of the valve using both hands. Left hand holding the system, right hand holding the wire. If wire is pushed, the valve is elevated. If wire is not pushed, valve deep dive.
This is very, very interesting what he just said. I don't know if you noticed the operators here in the audience. Not many people are doing it. Usually, the first operator is operating the valve, the second operator is doing the wire. What Dr. Kim is doing is fascinating and very, very important to mention, because you see the second operator is opening and he is controlling both the valve and the wire. And this is very smart.
Test it. Okay. Until now, the depth is good. Deploy.
Yeah, also the tension of the wire is very important. Yeah.
Deploy.
By the one operator.
Because he can control both, and he knows exactly how much he wants to push.
Pop up.
Pop up.
Already.
Yeah,
저장하고. Capture.
but you see the valve is so forgiving. So you're not afraid like the old days of the core valve.
풀해야지. Initial site is too high. Okay, that's this. Test it.
By the way, while he's working, sometimes when the valve is more horizontal, when you want to recapture, you have to take the valve
Test.
back to a place where it is straight and not on the part of the horizontal.
저장하고요. I restart
But in this
the
case, it's
deployment
okay.
because hemodynamics are stable. Deploy. 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 Stop. Testing. Okay, a little bit deeper than previous. Deploy. 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 Stop. Testing. About 6 or 8. Deploy.
I think he might need at certain point rapid pacing here, because there is almost no
Test it.
calcium. So when the valve opens,
That's a good idea. So pacing ready. 100. 100.
The constraint pacing.
Okay, testing. Deploy. 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 Deploy.
We have a BP drop right now.
Deploy.
Deploy. 끝까지 가겠습니다.
Deploy. Stop pacing. Testing. 저장하고요. 자, can you see the T? ECG is complete AV block, rate 40. (20% oversizing).
There was trivial to
40으로
by
낮춰봐.
PVL at 12 o'clock.
No conduction, AV block. How about TE?
At 12 o'clock, there was
Cross section,
trivial to mild AR PVL.
cross section.
Yes.
What about MR?
12 o'clock, there is pinpoint regurgitation. As you can see,
I mean mitral regurgitation.
Could you go to the fourth chamber again?
the
Swelling.
hemodynamic looks fine.
swelling regurgitation.
Yeah.
Emma?
I think because the valve touched the mitral valve, the anterior leaflet, so that it can make some functional MR, or
You cannot
Usually-
you cannot respect this right now, because first of all, the implantation is pretty high. So you do not suspect the fact that they are touching the mitral apparatus?
치워보고.
But the long axis will actually the tip of the valve
자,
touch.
I know, but it is still
맞춰볼까?
during the implantation. You cannot appreciate it. Have a look. It's a pretty high implantation. Now he's taking it a little bit LAO and a little bit
맞네, 그치?
lateral. So
맞지?
now the valve is
자, 갑니다.
perpendicular while the annulus is not. Okay?
A little bit high.
And it looks very nice. I would go for it. I think it's a very nice position, and it will enable you to post-dilate. You don't want to be on the 0 or 1 or 2
Is it a
millimeters here.
sinus rhythm right now?
Yeah. The ECG changed to sinus rhythm with AV conduction good and LBBB. Okay? Can you see the ECG?
Yes.
Then 20% oversizing, the depth is good. Thus I just released the system. Once again, I checked the depth in another projection, left. It is very important to project, to determine the angle with en face view. left로 하라니까. 좀 더 해보라고. 정말 말 안 듣네, 이동준 오늘. 약간 크라니오. 맞아? Okay. Here, another tangential view. Here, depth is about 2 or 3 millimeter, non-coronary cusp. Thus, I think 20% oversizing may alleviate the leakage, and such a kind of high implantation may alleviate AV block, even though we achieve 20% oversizing. Then I would like to release the final stage with tension relief, or just advance the whole system a little bit to prevent pop off. 아까 각도로 해가지고. 나도 이거 살게. 오케이. 자, I release tension by pulling the wire and advance the system. Okay, slow release.
And you push the system, right? While he is
Pull the
releasing.
wire, advance the system.
Yeah.
Release. Stop. 아까 그 노말로 좀 올려줄까? 잘 안 보이네. 관객들 잘 모르겠네. 오케이. Release.
Release,
Release.
release,
Release.
release.
A little deeper on non-coronary
Very nice.
cusp. Release.
We have one pedal out.
Release. Okay. Fully deployed. Test. Okay.
Beautiful implantation.
Then I retrieve the nose cone. It is very critical because, unfortunately, the proximal part of nose cone is abrupt, not a smooth shape. I have one case of valve distal migration during while retrieve the nose cone. Especially in that case, there is an expansion of non-coronary side. Thus, when we retrieve the nose cone, we have to avoid touch of nose cone and valve frame non-coronary side, like this. 오케이. 저장하고요. 자, 뽑을게요. Y stay. 오케이, capture.
Recapture.
Okay. Then I remove the pigtail. To remove. So I'm gently removing the pigtail with thermal guidance. Yeah. Can you evaluate T?
Yes.
There is intravalvular regurgitation due to stiff wire.
There is only trivial PBL at
Please show.
12 o'clock.
Pinpoint regurgitation paravalvular at 12 o'clock. Can you see once again? YST.
It's only trivial PBL.
12 o'clock pinpoint
Yes.
paravalvular regurgitation. Before removal of stiff wire, we once again checked valve frame in different angles and perform angiogram. Okay. Oversizing this is high enough, thus I changed the stiff wire into pituitary catheter LV. Then perform angio. No? Directly double tracing? Okay. So, baseline. So you can see the T while we are manipulating. Pulse pressure is wide, as previously, before TAVI. 그래서 먼저 엔조를 봐야 된다. When we see the pulse wave, there's two components of diastolic phase. The first phase is from peak to dichrotic notch. That pressure difference may correspond to stiffness of aorta. Second component of diastole is from dichrotic notch to end diastolic pressure. That is more appropriately related with paravalvular leakage. In this case, first component is very high, suggesting stiff aorta. Second component is very narrow, suggesting regurgitation is mild.
I think this is extremely important, what is just said. We call it in very simpler words, the memory of the AI index. A patient that starts the procedure with a hemodynamic that looks like this because of non-compliance, because of AI before the procedure, is not going to change it pretty much immediately after the procedure, and you should not, and that's exactly what he just said. That's important.
안 맞아, 위가. 거꾸로.
This is a fantastic result. Let me ask the operators and the panel what they would do about the new left
Just
bundle
sit
branch block with this self-expanding valve, the likelihood of ultimate complete heart block, and your consideration for monitoring versus placing of a pacemaker.
Okay, stop.
Anyone in the panel want to give his
Sure.
experience, opinion?
I would like to just wait for 1 or 2 days so that whether
what's the
the
final-
ECG can be changed into better run.
Final
But
index?
otherwise, maybe need to consider the pacemaker implantation.
Yeah, in this case, we should perform the post-dilatation. This patient has a lower diastolic pressure, and this angiogram shows a mild to moderate PVR. So, and the stent frame not dilated to the left-sided,
Once again.
not full dilated. So we should perform
Sit
the
there.
post-dilatation.
ですね。
But the
Well,
angiogram
I
shows
think that the PVL is definitely no more than mild, and the question now is whether you should post-dilate with a mild dilatation. Now, I'll be honest with you, there is no true answer for this, in my opinion, except my ego. And usually, I'm saying all the time that we are, after those times that we are giving up and do not post-dilate mild. I think that in this case, it's not even mild. Have a look. From one injection to the other, it disappears completely, which is one of the advantages of the Pro with the outer skirt. So I think that in this case, I would not post-dilate. And regarding your question of the LBBB, you know, like all of us, that there is no real answer. And I think that one of the main unmet needs in TAVI today is the electrophysiology.
I mean, I think if you did a survey of 100 people, you'd have a range of opinions. And it surprises me that even now, a decade into TAVR, we still don't understand the natural history of conduction disturbance, what it means to have transient disturbance during the TAVR, what it means to have transient or permanent left bundle. It surprises me that we don't yet understand that.
Well, this is an alert for all of us. You know, I always say that the main predictor of pacemaker implantation after TAVI is not the depth of implantation and not the LBBB. It's who is the electrophysiologist in your department. Who is the one who decides?
Plus, Angel Plus.
Yeah, so we need more data, no doubt about it.
Angel Plus.
Dr. Kim, I think we think you have very, very nice results.
Plus.
What do the ECHO says?
Yeah, echo. Yeah, you can see the.
Yeah, I can see
PE.
now.
Yeah.
We think that the echo is at most mild PVL, at most.
No, there is a bad terminology. Trivial.
Trivial. Yes,
Trivial.
trivial. Well,
No,
there was a
Why you are accustomed to mild? Trivial. We already perform a 20% oversizing. There is a suggestion, additional ballooning, but there are several factors to refrain from additional touch. The first one is already toward 20% oversizing. Second, LBBB already happened. Third, patient age is 85 years old. Fourth, when you touch more, that increase ischemic stroke. Of course, there is a severe under-expansion of valve frame we have to do. But as you can see, negligible valve frame distortion, no under-expansion, plus. 거꾸로 바꿔주고, minus. Here, there is a subtle under-expansion of NC, distal frame, but it's acceptable. Actually, regurgitant side is contralateral. Thus, considering such kind of complex situation, I really proponent of additional ballooning to correct underexpanded valve frame, but in this case, it's not. Plus. Okay, T finally 보여주면. The pinpoint regurgitation on T is just between non-CC and LCC. Can you see the CT previous slide? 한승문 선생. Okay, slide CT. 보여줘야지. 마이너스. 마이너스. Okay, here on left panel, there is NC left on the LC right side. When you see the CT angiogram, there is a subtle calcification on the commissure between NC and LC, or LC and RC. But actual regurgitation happened commissure between NC and LC. Such a kind of mild calcification may cause pinpoint regurgitation because its localization is adjacent to commissure. If heavy calcification is on the valve leaflet or valve body, that is not problem. That does not matter. But even though the calcium amount is very subtle, its location is kind of adjacent to commissure, that may cause pinpoint regurgitation. CT를 안 보여줬나 그동안? 오케이. Thus, it is just NC and LC. Thus, actual regurgitant flow is behind on the angio screen. Angio, please. As you can see, the regurgitant fraction appears on the left side, NC. Actual, that origin is between NC and LC.
So, Dr. Kim,
Yeah.
this patient presented with the new left bundle branch block. So, how long are you going to monitor of this patient?
For this case, it may aggravate as time passes. When you analyze more than 250 patients, the complete AV block usually happens immediately after procedure, not 1 or 2 or 3 days later, but some cases happen complete AV block, even 4 days later or 7 days later. Thus, we cannot expect what happened in the near future for these patients. Thus, my plan is always I let the patient overnight in CCU with the pacing catheter on site from right jugular vein. Then if it is okay, we can remove the pacing catheter noon tomorrow. But if there is a happening, just transient complete AV block, we have to wait 3 days more. Then there is a change of complete AV block or LBBB, then we implant permanent pacemaker. If there is no transient AV block, then we remove all system and wait for the change of ECG for additional 7 days in the general ward. If it's okay, then we always discharge the patients. Thus, in terms of conduction delay, we are really conservative.
Okay, I think that we are all in agreement here that results are beautiful. You should monitor the patient for the LBBB, of course, and this is something that is not completely understood worldwide. And you are gonna now close the artery, and we're gonna move for the next room. Yeah, Dr. Kim, congratulations, beautiful work.
Okay, thank you very much. Bye-bye.